All right, tonight we're going to be doing Glaucoma Yes or Glaucoma No. This is Education Consultants National Webinar Series, Tuesday night edition. I'm going to be the speaker, and Greg is going to support me and help me out when I get stuck on anything, or he has an insightful comment, because Greg does a heck of a lot of glaucoma as well. And the where this came from, this title came from, sometimes you do things inadvertently and it seems to resonate and stick. And that's what happened here. For 26 years, when I was at Nova, I was there for 28 years and 2 days. But I taught the glaucoma course for 26 years. And when we went into optic nerve analysis, I would describe it, and then we would just put up images, and I would ask, glaucoma yes or glaucoma no. And for some reason, that seemed to resonate with students. That seems to be the aspect of my teaching they seem to remember the most, the glaucoma yes or glaucoma no. I see that on social media. So I put it together as a lecture, and it kind of brings me back. And we're going to have about 15 polling questions talking about glaucoma yes or glaucoma no. Now, these are my disclosures. I am on the speakers and advisory boards for Bausch & Lomb or Bausch Health. Got no financial interest in any products. Everything has been mitigated. And I am a co-owner, along with Greg, of Optometric Education Consultants. And I have created this independently, my presentation. So people ask, or I've heard, what is a glaucoma standard of care? What do you need to do to meet good glaucoma care? And what is the standard? And I've always said there is about 4 aspects that we really need to do. IOP measurement, I'm going to say IOP measurement of some sort. Historically, we rely on Goldmann applanation, but as I'm sure everybody knows, that is got some inter-observer variability. It's tough to learn as a student, and I can imagine that, it's only as good as your technician. There are some devices out there that are FDA approved for the measurement of intraocular pressure, and sometimes in certain situations that can be advantageous. But traditionally, we have leaned toward applanation tonometry, Goldmann applanation. Often overlooked is gonioscopy. You can't correctly categorize any type of glaucoma without knowing the status of the angle. Is there a secondary condition? Is it an intermittent or chronic angle closure, or even acute angle closure? We can't rely just on the von Herrick angle. We have to look at gonioscopy. Threshold perimetry, and I'm not going to tell you any device is better than the others. Historically, we use the Humphrey field analyzer, but that is just widespread. But I'm not going to try to claim superiority or inferiority of anything out there. But the ability to do threshold perimetry is part of our standard. And to be able to critically observe the optic nerve. Now, I'd like to say stereoscopically, but I don't want to bias any of our amblyopic or monocular colleagues, but a good look, preferably stereoscopic, at the optic nerve. And this meets glaucoma standard of care. And if you ask me, this is not only just standard care, this is good glaucoma care right here. Now, if we want to get sophisticated, well, we're going to add pachymetry in there to see what that relative risk factor is of the central corneal thickness. If we want to climb a little higher on the tree or up the ladder, we'll add diagnostic imaging, OCT, OCTA, disc photography, and wide field imaging. If we want to go a little higher, we can look at another risk factor, corneal hysteresis, using the oral response analyzer. And there's also visual electrophysiology. Now, the question is, how much information do we need? Is there a point where there's too much information that we become paralyzed, paralysis through analysis? And what is really important to examine? Well, after all these years, glaucoma is still a primary optic neuropathy. And because it's a primary optic neuropathy, I think we really need to look at the optic nerve. And in my opinion, the goal of a good glaucoma practitioner should be to be able to diagnose or at least strongly suspect glaucoma based upon optic nerve appearance independent of anything else. And if we want to go even further, to try to be able to determine if a patient is stable or progressing based upon optic nerve analysis. So that's really, really high glaucoma care. And it comes simply down to looking at the optic nerve. And that's what we really need to do. And it is, I'm afraid, becoming a bit of a lost art or lost skill. I was doing a program. I had a fellowship trained glaucoma specialist from Bascom Palmer. And in the panel, he actually got up and said, "You're not going to believe me when I say this. As a glaucoma specialist, he goes, but I'm not that good at looking at the optic nerve. I grew up in the area of the OCT, and I really look at the OCT." He actually admitted, he said, "I'm not that good at it," which I think was a pretty good amount of humility. So making suspicion of glaucoma based upon disc appearance, a couple things to remember. Larger discs will have larger cups, but the rim is intact. And glaucoma is going to be overdiagnosed in larger nerves and underdiagnosed in smaller nerves. It all depends on the size of that cortical canal and whether or not those 1.2 million axons are going through there. Are they going through crowded or are they going through spaciously, as we say on the left? So evaluating the optic nerve in glaucoma, that's really the most one I'm going to spend a bit of time on tonight, and we're going to really emphasize it. Understand the characteristic. Yeah.
As you're doing that, there was a good question
Yes.
that came in, and you can fit it in where you like as you go through this. It says, when is a thin temporal neuroretinal rim a concern, supposing superior temporal and inferior temporal neuroretinal is thick? Does it relate to glaucoma or mainly neuro? So you fit that in wherever you want. You kind of had a picture of it back of kind of a little bit of a thin rim temporally and kind of normal neuroretinal rim a couple slides back. But
That's
you
really,
take that whenever you want.
yeah, I can do that right now. That's really a very good question because there's certain glaucoma prone zones, inferior temporal, superior temporal, nasal, and strict temporal are relatively well preserved. So that is not a concern. If superior and inferior rim is good, temporal thinning is an anomaly. It's a malinserted nerve. It is crescent. And it's actually, the question is very prophetic because this is going to come up in a little bit, and hopefully this will answer the question. But I don't worry about thin temporal rims. If I have to make a diagnosis of glaucoma based upon temporal rim damage, the rest of the nerve has been compromised. Just like nasalization, and I'll show you some examples of nasalization. Nasalization is sort of a end stage type of situation. We don't make diagnoses of glaucoma based upon nasalization because there's just too much other damage. That's a really good question. Temporal rim, I am not worried about. It's superior temporal, inferior temporal. Because characteristic glaucomatous neuropathies, it's focal rim damage, not a concentric enlargement like we see on the right. It's that focal neuroretinal rim notch that we see on the left. And I'm going to tell you right now, I'll probably repeat myself, nothing notches a nerve like glaucoma. Tumors don't do it. Trauma doesn't do it. Infection, infarction, infiltration doesn't do it. A focally damaged neuroretinal rim is really very specific for a glaucoma. So here's where we're still talking like cavemen. If we talk about glaucoma in cup to disc ratio. Now, interestingly, it's actually in my practice act, Greg, in the state of Florida, I have to write a cup to disc ratio. It's the law. It's not important to me. There's a high degree of inter-observer variation. You and I can differ by 0.2 CD ratio, yet we're still both good glaucoma practitioners. And I can even disagree with myself by a 0.1 from year to year. But we don't want to talk too much about cup to gift ratio. We want to do a critical disc evaluation. There's 6 things I'm going to look at. What is the size of the optic nerve? What is the rim color? It should be pink and perfused, not pale. Are there focal rim defects, i.e. notching? Are there hemorrhages, and are they in the right place and the right consistency? Are there nerve fiber layer defects observable clinically? And is there peripapillary atrophy? These are all the 6 things that I work through when I look at an optic nerve. Now, size is important, and I will assess size when I look at the parameters on an OCT. But I just break it down to what does it look like to me? Does the nerve look small? Does it look average? Does it look large? That is just the subjective interpretation. But the important thing is when I cut this optic nerve in half, I go, and is my pointer coming through, Greg?
It is.
It is? Okay.
Yep.
When I cut this optic nerve in half, does the bottom look like the top? Is it relatively the same? And if that is, that's a good looking nerve. Now we take a look at this, and this is size. Size does matter. I cut this nerve in half. What do we see here? The bottom and the top look pretty close to me. Now it is an impressive looking nerve. It is deep. I can almost hear my voice echoing as I look at this optic nerve. We see the laminar pores, so it's very, very deep. And we see a nasalization. And what that means is there is a shift or a displacement of tissue, so the vessels move nasally. Now, this is a tremendously large nerve. Compare that from here to the distance to the macula. It's a very small distance. That is a megalopapillae. But I cut it in half, and the bottom looks relatively like the top to me, and that is something I don't worry about. Color. It should be pink and perfused. We look at here, all this rim tissue, and it's actually relatively narrow. There's a lot of pinkness. It is well perfused. This nerve is very, very well perfused. In this patient, this was a glaucoma suspect with a patient with the pressures in the low 20s in one eye and 30 in the other. We have a good pink rim tissue here, but we have relative pallor. This is pallor in excess of cupping. When we have rim tissue that is demonstrably pale, and that's why I like photographs, not so much the digital imaging, but I like the photographs. I can compare the size, I can compare the appearance, and I can look at the color difference, and we can see that this is a patient that doesn't have only glaucoma, but actually has a bitemporal defect and some posterior optic nerve compression on the left side corresponding to this disc pallor. Pallor of the neuroretinal rim is nothing that we're going to be seeing in glaucoma. Now, I'm not talking about the 0.95 cup where everything looks pale because you're looking at glial tissue and scleral tissue. I'm talking at 0.6, 0.7 CD ratio where you can see demonstrable pallor. And in this case, the patient also did have reduced visual acuity. So when I take a look at it, we have a nerve that is relatively perfused. I don't see any pallor, but I cut the nerve in half. And there is a rule that we all think about. We probably have all learned it, and that's the isn't rule. ISNT. In most normal situations, there is a relative thickness descending in order of the neuroretinal rim, where isn't I inferior is the thickest, S superior is the next thickest, N nasal is the next thickest, and T temporal is the thinnest. So I take a look at this, I cut in half. I have the inferior rim here with the bend of the vessels. It is thinner superiorly, probably significantly thinner, and the nasal is actually thicker than superior. So to me, this would violate the isn't rule, and it seems as though there might be some rim compromise. And when I cut the nerve in half visually, the bottom does not look like the top to me. So this is one that violates the isn't rule, and this is a nerve that is going to be immediately suspect to me. Now I take a look at this nerve, and I'm going to cut it in half. I'm going to look, does it violate the isn't rule? Or even more simply, does the bottom and top look alike? It looks like I've got some rim tissue to about here. But if you look at the bend of the vessels here, very, very sharp, very thin superior rim. I go over here to the nasal, and I think the nasal aspect is a little bit thicker. And even the temporal aspect is thicker than the superior. So this would be actually a very suspicious nerve, or what I would call a glaucoma yes. And it looks like we have focal loss of neural retinal rim superiorly. Greg, any thoughts on anything so far? Anything you want to throw in?
No, I am a big fan of, like you said, symmetry, and isn't rule. So nothing to add, just echoing to
Mhm.
what you have. Along with the question I read to you before, I'm not sure what GCA is. I mean, I know it's giant cell arteritis, but how do you use GCA to judge glaucoma risk? Um, I'm,
Oh, that's
um,
good. Ganglion cell analysis.
okay, perfect.
And the answer is I don't use it to assess risk as much as I do to assess disease. And there's some characteristic patterns I'm going to pull up in just a little bit, but it is actually a pretty significant and critical, and maybe I guess this may actually be the first time I'm thinking about this and saying this, but it actually may be more diagnostic than actually the nerve fiber layer on an OCT. But ganglion cell analysis is actually very, very critically important. The only thing dodgy about it is if there is concurrent maculopathy, it can sometimes be misleading.
Is that a Zeiss terminology?
No, no, I think it's nothing to Zeiss terminology. I think it's just a maybe regional terminology because I've heard of that in other meetings. I've heard people call it GCA, and I'm a GCC person, but I know GCA ganglion cell analysis is a little bit less common term. I don't use it because I talk about giant cell arteritis all the time. That kind of confuses me. But
The
this
only
is what you're
comment
looking
that I'll
for.
make
Yeah.
on giant or the ganglion cell versus nerve fiber layer is that on an OCT, it's usually a little bit more accurate because as you acquire the ganglion cell, you're usually looking straight ahead. To get the nerve fiber layer, they have to fixate nasally to rotate that optic nerve. So if I was putting a little bit more accuracy in a measurement, I would say ganglion cell analysis, if you want to call it that, would be a little bit more, say maybe more accurate because of you're looking at it with your macula as opposed to essentially fixating. My 2 cents. So I'll let you rock and roll.
Yeah, I think yeah, I agree with you, Greg, and I'm thinking I get probably more false negatives with the RNFL analysis than I do with a ganglion cell analysis or ganglion cell complex. But this is what we're looking for, focal neural retinal rim damage, what we call the quote unquote notch. You can actually even see there's a little bit of a hemorrhage right there at the edge. Glaucoma, nothing else does this. Tumors don't do it, trauma doesn't do it. Here we have a focally damaged neural retinal rim that is otherwise peak and perfused. Yeah, this is glaucoma. I don't see anything else that would give this appearance. But it's important to look at the contour of the vessel. This is actually a patient that had been sent to me in consultation for neurologic disease because the patient had extreme field loss and was judged to have a 0.5 CD ratio. But if you look by color, it looks like a fairly small cup. But if you look by contour, where the vessels are coming out, all right. This is a very, very large compromised neuroretinal rim. It was really actually nothing but glaucoma. And in most cases, when we have significant structural damage, we're going to have concurrent functional damage. We can actually see if I cut here in the middle, the top doesn't look like the bottom. Bottom doesn't look like the top. We can actually see a very sharp delineation here. Sometimes this has been called bayoneting. I don't really care for that term very much. Some people call this bean potting because we're losing sight of the vessels because it's kind of going backwards there. I like to call this notching or focal neuroretinal rim damage. Now, as you see on this one, this is advanced disease. I probably have no neuroretinal rim from about here to about here. So several clock hours, there is no neuroretinal rim. And the rest of the nerve is very compromised, but look at the rim tissue. The important thing here is it is still pink and perfused. Now, you may say this nerve is pale because you're looking at scleral tissue, but the remaining nerve tissue is actually very well preserved. Now, disc hemorrhages. The enigma of disc hemorrhages. They tend to form on the glaucoma-prone zones. Inferior temple, superior temple. And I guess maybe, Greg, we should probably clarify glaucoma-prone zones. The laminar curbosa has a differing level of support, lesser, superiorly and inferior for those ganglion cell bundle axons going through than nasal and temple. That's pretty well supported. So because of that, the laminar curbosa tends to collapse more superiorly and inferiorly, leading to compromise of those ganglion cell bundles. So we always look in the glaucoma-prone zones as inferior temporal, superior temporal. This really accounts for virtually all true glaucomatous disc hemorrhages. And they usually occur where notches and neurofiber layer defects. Now, when we have hemorrhages in other areas of the disc, such as strict nasal, strict temporal, or well within the cup, they tend not to be associated with glaucoma. And what I'm looking for is a nerve fiber layer, or sometimes known as splinter hemorrhage, flame-shaped hemorrhage, in the neuroretinal rim. I want it to be relatively small. It should be contiguous with the neuroretinal rim, and it will usually be in that glaucoma-prone zone. We can certainly see a flame-shaped hemorrhage here in an area of focal deficit of the neuroretinal rim. And this is really part and parcel as to what's going on, more likely than not. Enhanced depth imaging OCT has really shown that there's a mechanical shifting of the tissue in the laminar curbosa, which we cannot see clinically, but we see it on enhanced depth imaging OCT. And it will cause a shearing of the microvasculature, leading to this congestive disc hemorrhage. And these are long-standing glaucoma patients that I have seen. We can see an inferior temporal disc hemorrhage. The neuroretinal rim is not all that compromised. We got some thinning here, but you can see there's a little bit of a nerve fiber layer deficit along with it. In this patient, small glaucoma-prone zone, superior temporal, flame-shaped in the nerve fiber layer, contiguous with the neuroretinal rim, and this is pretty classic. And again, in another patient, inferior temporal, contiguous. When they show in other areas, I have to acknowledge that it could be something else. Now, all that being said, these are ephemeral, about 6 weeks. Do you agree with that, Greg? Do you see them go longer or shorter? I think it's kind of really hard to tell.
Yeah, I think 6 weeks is a good number.
Yeah. So a lot of it comes down to when you see the patient. If you see a patient 3 or 4 times a year, I'm going to say you will probably look at the optic nerve every time, even if it's undilated. And when I look undilated, I am looking for a disc hemorrhage. But just by chance, patient may not come in when they have a disc hemorrhage. We can easily miss them depending on when they occur. Now, It has been shown in the early manifest glaucoma trial that not every patient with glaucoma will develop a disc hemorrhage. And they also show you can't stop them from happening just by lowering intraocular pressure. So there's a heck of a lot we still don't really know. But what we do know is when we see disc hemorrhages, structural changes and functional changes are more likely to subsequently occur. Now, there was a time when asked, so I would say I don't consider a disc hemorrhage itself to be progression, because to me progression always meant something that would not revert. Neurofiber layer loss doesn't revert and get better. Disc notching doesn't get better. True visual field loss, except for some fluctuations, tends not to get better. These are ephemeral. Now, I've changed that thinking because we now know there's a shifting of the laminar tissue in that area, and that is something that won't change. If it shifts and it bows backwards and it compresses vessels, that is really progression. So I actually do say this is an eye that's getting worse, at least structurally, but maybe not functionally until we test them. And they tend to be recurrent,
Hey,
and they
Joe,
tend to recur in the same place. Yeah, Greg.
pause for a second, go back to your first
Yeah.
one, because I want to see if this holds true as you go through. One more. There it is. So if you can, with your pointer inferior to that hemorrhage, show the nerve fiber layer dropout, because you can see it there. So there's the nerve fiber layer dropout where Joe's pointing. When you already have dropout on the nerve fiber layer, usually the hemorrhage, if you're trying to determine if it's from glaucoma or if it's from maybe a PVD, Joe has described it perfectly. It's attaching to the nerve. It's usually superior, inferior, superior temporal, inferior, superior and inferior temporal in that glaucoma prone zone. But if you look, it's just adjacent to where that nerve fiber layer dropout is. And in this case, it's superior to the adjacent tissue, and it's kind of spreading in that area. On the next slide, you can kind of see on your third picture over that, you can kind of see again the neuroretinal rim dropout where the nerve fiber layer loss is, and that one's kind of adjacent to it. So when you go to the next pictures, I just kind of want to see show people
Yeah,
that in some of these advanced cases where that is. So
Greg, if you want to take over here, I think this really shows what you were just
yeah,
describing.
yeah, go
Same
ahead.
person,
Yep.
three different ones. We can see right there we have a disc hemorrhage, and what is adjacent to it is a nice wedge defect. Now we have a disc hemorrhage down here at the edge. Then we have another one in here. And one thing to point out is look how much wider that's getting. So this is very characteristic, as you said. It tends to happen at that junction. And I guess if we have another one, I mean, if we have one here, maybe it'll start expanding that way. But they tend to recur in generally the same area, not exactly the same space, but in generally the same area. And this is an area where the laminar cribrosa is especially fragile. Now here too, I kind of don't worry so much about. Here's a hemorrhage, as I like to say, and you have to listen to it a couple times. I've always said, not all hemorrhages of the disc are disc hemorrhages. This is a hemorrhage of the disc, and here's a patient with a hemorrhage in the cup. It is not in the nerve fiber layer. It is not in the glaucoma prone zone, and this is a patient who had a posterior vitreal detachment. Now, this patient, this was actually sent to me in consult. I don't think I ever saw the patient, but it was a, hey, let's take a look at this. And this is not PAL, this is just overexposure. They're asking about the disc hemorrhage. And I tried to explain this is a hemorrhage of the disc. This is not a disc hemorrhage because it is in the glaucoma prone zone. Yes. It's in the nerve fiber layer. Yes. It is contiguous with a neuroretinal rim. Yes. But if we look at how far some hemorrhages are occurring out here, you can tell that's a little bit too big. And this vasculature, these are collateral vessels. This is a patient who actually underwent a branch vein occlusion that is resolving and is mimicking a glaucomatous hemorrhage, but this is not glaucoma. Now, all these other little hemorrhages that happen on the disc really aren't going to do anything. They're not going to result in any of the classic changes that we've talked about. Now, this is a nice example of what it is when they do. This was an ocular hypertensive patient and has a very good and robust nerve fiber layer right here. And we can see a small flame-shaped hemorrhage, inferior temporal, small nerve fiber layer, contiguous with the neuroretinal rim, glaucoma-prone zone. Over the course of a year, what happens? Now we have dropout. None of the other hemorrhages are going to do this. It only happens with the true glaucomatous disc hemorrhages. And now, this is a sign there's a shifting in tissue. It is now affecting the ganglion cells that are going through that area. And we have now nerve fiber layer dropout. Now let's look at a couple other things. Parapapillary atrophy. When I was teaching the course, I would always tell the students, I tell the residents, when I'm writing test questions, parapapillary atrophy alone will never be the answer. Now, we know that parapapillary atrophy does occur in glaucoma. I don't know if we're really certain that it is a epiphenomenon of glaucoma, or it is a predisposing situation for glaucoma to develop. But it's important to look at it, and it has gotten entirely too complicated. They've tried to overanalyze this just too much. All right, there's really a couple zones we have to watch out for. Now, we see this nice little regular clear area here. That is a sclerocrescent. That is nothing more than that. That is normal anatomy. Adjacent to that, we have this irregular atrophic area, which we know as the beta zone. Beta zone has been associated with glaucoma, probably more significant than any of the others. And we go a little further out, we have the alpha zone, which is this pigmented area out there, which is usually associated with normal patients. So that in itself is not considered glaucomas. Now, how do I use this? When I look at an optic nerve, my first assessment is, does the nerve look sick? I'm going to be looking at the size, the color, neuroretinal rim, nerve fiber layer, disc hemorrhages, paraplaque. Does it look sick? And when I see abnormal parapapillary areas, it makes me a little more suspicious because the nerve just doesn't look quite as good. Not to say that there's anything wrong. Parapapillary atrophy alone is never the answer. But this is a really good example of the zones which I just talked about. Here's a nice little sclerocrescent, very bright, pretty regular. Now, adjacent to it, we have this atrophic area. We can see a little deeper into the choroidal area. That is the beta zone. That tends to be associated with glaucoma. And then go a little further out, we have the alpha zone, which is this pigmented area. So this is very much an anomalous looking nerve, but if I cut the nerve in half, the bottom and the top do look the same. I think this is a tremendous example. This is a little bit of an obliquely inserted nerve. It looks like we don't really have much rim tissue here. If I were to cut the nerve itself in half, the bottom looks relatively like the top, but we have this nice beta zone right here. And the tessellation of the fundus really is kind of showing this in a very demonstrable way. We can see the choroidal vessels more, so the parapapillary area is somewhat atrophic, and a nice, really dense area of alpha zone. Now, as I said, parapapillary atrophy alone is never the diagnosis. It's never the answer. I can tell you, all these three are great examples of parapapillary atrophy were in normal students and residents. They just had great anatomy to look at. They had no glaucoma. And this is the only situation, I'm going to ask if you've had any situations like this, Greg, where I have ever seen, or I should say acknowledged or noted or tripped over, a changing parapapillary area. And this was a glaucoma patient. who had developed an increase in parapapillary atrophy over time. Greg, have you ever actually seen that?
Joe, quite when people ask me about peripapillary atrophy, I always say, look, I'm so confused about alpha and betas. I know I'm looking for change over time. I think this is the first time in maybe 15 years of understanding it, hearing lectures, that I truly understand it now. So now I'm going to go back and look and see if I can find you some of these changes. So goes back to show you how much I put towards peripapillary atrophy.
Yeah.
So.
And the answer is we have probably seen it, but we've never seen it. We don't notice it. It's nothing that we were looking for. This just happened to be. I've liked photographs. I took a lot of photographs and like, hey, that's interesting. Look where that came from. This is the only example I can think of, but I can say there are probably a number of other cases I've just not even noticed a change, or I've missed it. Now the question is, changing peripapillary atrophy, is that a sign of progression? The answer is we don't know. It's so infrequently reported. I don't think we have enough information about it, but it does change. Don't know what it means, but it does change occasionally. Now, anatomically, the optic nerve is, comprised of these bundles of axons that will arc around the horizontal raphe to form the optic nerve. We can see there's the greatest amalgamation of nerve fiber layer tends to be in this area here, superiorly and inferiorly. There's a relative paucity of nerve fiber layer in the papillomacular bundle, as there is in the nasal retina. So when we take a look at it anatomically, here's a person who's got a fairly large nerve, a fairly robust cup. I look at it in half. I don't see any difference from the bottom to the top. But as you follow the major arcades, you can see that nice sheen there. And it's not uncommon to have an area of paucity between these major vessels. We call a split bundle defect. It's not really a defect, it's an anatomic orientation. So we're mostly going to see that X, the X factor, so to speak, there. What we're looking for is to see that focal loss. And I cut it in half, and sometimes we have to look at the quality or the clarity of the superior part versus the inferior part. We can certainly see a large dark area of nerve fiber layer deficit here. Now, in this one, I'll share the history in just a second, but I want you all to concentrate on the optic nerve. Ignore everything, if you can. Ignore everything else, but just look at the optic nerve. Cupping is probably about 45 to 50% cup. Pink tissue, very nice. I cut it in half. Does the bottom look like the top? It does to me. The nerve itself looks pretty good, but we go afield and we look and we see a very large wedge defect. And we still have some here. This is eventually going to coalesce probably into one larger wedge defect, and we're probably going to eventually have compromise. Now, this was a patient who had recurrent uveitis, and when their uveitis recurred, their pressure would go into the 50s. So this is a person who's getting focal damage. It's not as chronic as in primary open-angle glaucoma. It is more an intermittent challenge to the optic nerve. But looking at the nerve fiber layer, we can see this is not a normal situation. Now we take a look at this one, and I look superior. I see some nice striations up here. Here's a nice, interesting. I think I just noticed this right here. You can see a darker area, but it stops right there. That's just an anatomic pseudo wedge defect. A true wedge defect has to go all the way to the optic nerve and has to be at least as large as an arterial. And this is not. This is just maybe a little bit of an anatomic blip. We look down here and we certainly see a large wedge, much larger than an arterial. And we do see some focal defects, and we lose that vessel, then it springs up in a bayonet or bean pot sort of area. And clearly this is a glaucomatous nerve. And again, if we take this and we cut it in half, I can see some striations up here. I get a large darkening down here, and we can see it's coincident with this very, very thin rim. Now, I actually remember this patient. I could name her by her optic nerve. Now, if I saw her in the grocery store, I might not recognize her, but I probably would. But I can name her by her optic nerve. And I know she has bilateral glaucoma. Her other nerve was not nearly as compromised, but her other nerve, in the course of my care, I saw no less, Greg, than 5 disc hemorrhages. They all occurred in the same place, and that nerve actually got worse over time. The field got worse. Now, in her fellow eye, I never saw a disc hemorrhage. And even though she has more advanced damage in this eye, there was no progression over time. And I'm talking, Greg, about 20 years. And I love taking the filters and looking at it red free. It is our friend. The camera can be our friend. We can certainly see here a larger wedge defect in the nerve fiber layer. We see it cutting right down, and the neuroretinal rim is only about this large. Now, yeah.
So, Joe, there's a question that rolled in a while back, and I was kind of waiting for the right time. It says, is red-free filter the best way to assess the cup to disc ratio? And we can go here and maybe talk about nerve fiber layer and neuroretinal rim. I'll just add to it. But the question is it the best way to assess the cup to disc ratio?
I don't know if it's the best way to assess the cup. I think it's probably, I mean, if we look at them, I think it's probably very helpful. I think it's actually very, very helpful. But it is the best to assess nerve fiber layer deficits. In fact, it is considered in ophthalmology the gold standard. Red-free photography of the nerve fiber layer. In fact, whenever they have done OCT studies, they compared against, when they look at parameters for what's the most sensitive aspect of the OCT, it's always compared against the gold standard, quote unquote, of red-free photography. But you can certainly see it does help us identify where the neuroretinal rim is here.
I'm going to make a comment on filters and then cameras. I'm going to just say the filters are on the cameras for a certain reason. So take advantage of those filters. Use the red freeze. There's the cameras out there now have multiple types of filters with blues and obviously the reds and the green freeze, so on and so forth. So manipulate those images. I'm lucky enough to have an Optomap and through eye care the Aiden, and I can see, Joe, that you're not using a lot of Optomap images here. I've had this dual camera system, if you want to say, and by photographing with my Aiden, I have no financial interest, I'm not promoting, I've gotten picked up a little bit more with that camera with those disc hemorrhages. The nerve fiber layer drops out, changing. It's just a different way of taking the picture. So I think, it depends on our technology. If we have OCT and maybe an Optomap and a visual field, we might push back on the photos saying they're not as helpful. But if you get yourself a high-end quality camera taking care of those nerves, I think you fall back into, I'm going to build a lecture of some really cool photos comparing the two systems and what I've missed and what I've seen by using the camera. So that's my comments on filters and cameras.
And those are great comments, Greg. And I was going to kind of go by this. I'm going to stop here for just a second and share something. I do talk about this. I don't know if I have a better example later on, so I don't think I do. So I'm going to talk about it right here. If you notice this vessel, this arterial, compared to the other arterials, it does seem rather sclerotic. And I'm going to help you all to avoid any unnecessary workup. This is not a branch retinal artery occlusion of any sort. This sclerotic vessel is not sclerotic. It is how the arterial should look. The reason the other ones look different is because there is a profound or profuse nerve fiber layer on top of it. But when you score it away and peel that nerve fiber layer away, now we're seeing the arterial as it really is, and it may actually seem sclerotic. It is not a branch artery occlusion. It is an area of profound nerve fiber layer damage. Now, there's actually a technical term for this, Greg, and you may not know what it is. In fact, very few people know. This is actually known as a pseudosclerotic vessel of Sowka, because I think I'm the only one who's ever talked about it.
Joe, you taught that 8 to 10 years ago to me, and I can't tell you how valuable it's been, because I used to be like, oh, geez, look at that. No, look at that. Look at that artery. Are they at risk? Should I be working them up? And when you taught that basically it's a naked base artery, it's not covered with the other, the nerve fiber layer and other retinal components, that's the way it looks. That actually just allows me to exhale when I see that in the inpatient care.
So what we have here, Greg, is a nice way, and I appreciate those kind words. I'm glad I was able to help. But we have this wedge defect. We can certainly see right in that area. There's a disc hemorrhage.
Right adjacent.
Now I'm going to throw you something. To put this in the chat box, guys. Greg, if you'll, what is the percentage of undiagnosed glaucoma in the USA? Put it in the chat box. What do you think? How much glaucoma is undiagnosed that exists in the U.S. is undiagnosed? What do you think? And I'm going to share with you some important information that may help you somewhere down the line.
All right, here they come. Took a little time, but now they're rolling in. 25, 65, 50, 35, 80, 60, 65, 40, 40, 10, 22, 70, 40, 30, 35, 50, 70, 50, 50.
And the answer is 50%. 50% of all the glaucoma in the United States is undiagnosed. Now I'm going to share with you another caveat, another quick little pearl. What's the percentage of undiagnosed glaucoma in Australia? It's 50%. What is it in Germany? It's 50%. Anywhere in the developed world, it's 50% undiagnosed glaucoma. And I'm just going to talk real briefly about this population-based Thessaloniki eye study. This was 2,500 people over 60 in a population-based study looking at a number of things. There is a 50% rate of undiagnosed glaucoma. What was even actually more shocking, the prevalence of overdiagnosed glaucoma was 2/3. Only about a third of the patients who had been previously diagnosed and treated for glaucoma, including, Greg, lasers and surgery, could have the diagnosis actually verified. So it tells us we're doing kind of, we could be doing a little bit better. We're missing half of them, but we're trying to make up missing the half by overdiagnosing 2/3 of them. All right, so this brings me to my first polling question. Based upon the optic nerve, is this glaucoma yes or glaucoma no?
So let me launch that. Well, let me read the question here before I launch it. There's something that popped in. It says percentage of glaucoma patients undiagnosed or percentage of population undiagnosed. That was the question that rolled in.
So I think it's probably the percentage of population of glaucoma patients who have not been diagnosed. It's about 50%. We'll identify 50% of the patients, but we have to be careful that we don't overdiagnose and overtreat. So is this based upon what we talked about so far? Is this a glaucoma yes or a glaucoma no?
I'm gonna kind of go off of one of your pearls that you went over a little earlier today. Larger nerves are overdiagnosed and smaller nerves underdiagnosed. And I think in the last 6 weeks, I was in a run there. I stopped more glaucoma meds than I think I started. Not followed patients, but the initial starts. And they were all pretty much macro discs. When you they look thin, really not much violation to the isn't rule. Maybe they're equal, superior to inferior, but when they ran the OCTs, great superior and inferior. And when you look back, they were all pretty much macro discs. So it kind of goes back, and we could maybe, if I could find those cases, put that right in there with that slide of showing all those nerves, put the OCTs beside them, and show how they all looked great. And they were normal tensive glaucoma diagnosis, and they were taking pressures of 20 and taking their cornea thickness of 520 and saying, "Oh, that must be high." And I mean, they were really talking them into, in a sense, glaucoma. I stopped the medications. So
Yeah, it's actually important, Greg, to be able to have the wherewithal to stop a medicine. Now, I had a patient who I've been following for a bit of time. He actually popped an emboli during knee surgery and developed a branch artery occlusion. This is historical. We know that. He came to me on medicines, and he had kind of told me that it was being done prophylactically, just to protect the eye. It was either treating both eyes, and the other eye seemed fine. The other one eye had a very dense scotoma from the artery occlusion. I said, I'm not really sure if prophylactically treating is beneficial. Let's stop the medicine. So I stopped his latanoprost. And about a month later, his pressure went up by about 2 points in each eye, and said, "Okay, we're fine. We're going to leave you off." And I just saw him for a 4-month follow-up, and his pressure now had risen to 26 and 27. I said, "Okay, now we know we can put you back on. It probably will help." So what is it? What is it? Glaucoma yes or glaucoma no?
well, I should have cut you off about 10 seconds ago, because it was exactly 50-50. But now
Excellent.
it's 37-36 yes. So we converted to 51% saying yes, 49% saying no.
Well, guys, cut this in half. Does the bottom look like the top? Look at my neuroretinal rim there. I come down, follow the vessel, it dips down, and now it comes back over the rim edge, and we can see that's about it right there. Bottom does not look like the top, violates isn't rule, focal defect. This is glaucoma. This is a glaucoma yes. All right, is this glaucoma yes or glaucoma no? Let's do number 2. We won't let this one go too long.
Okay, let me stop to disclose it. Let me get number 2 opened up here. It's now open. Number 2 is open.
Is this a glaucoma yes or glaucoma no? Do the same disc analysis that we do. And we're going to have a couple in rapid succession, Greg.
Okay, that's fine. I am ready. And looks like we've learned off the first case. Okay, I think we've got pretty much everyone weighed in. I'll display the answer. This one's leaning towards yes, 75%, and 25% saying no.
So I cut the nerve in half. Does the bottom look like the top? Well, top. I can see some vessels bending there. This looks like the edge of my rim tissue. I come down here. We can kind of see a bayoneting, and the rim tissue is really down here. So this is a glaucoma yes.
All right,
let's hit this one.
we got a
Yeah.
question that rolled in.
All right,
I'll let you answer the question, and then we'll open up this poll, or we'll have you answer the question. It says, has anyone associated greater chance of glaucoma in a patient population that had LASIK in the early days? And so, Joe, I'll let you answer that. And then Henry, I'm kind of curious, why would you think that? So Joe, answer it, and then just where are you going, because you said early days, and I'm going to go open up the question.
Well, there's two thoughts. One could be, are we underdiagnosing the pressure because we have a thin cornea? I'm not sure that's where you're going with that. I mean, I think what you might be talking about is when they use the microkeratome, they pumped it up to suck and vacuum up that cornea. They pumped it up to a 60 millimeter pressure so they can make the cut. did that cause damage? And Greg, to my knowledge, I don't think that it has. But they would tell patients, when we're doing the procedure, the cut, there'll be a brief period of time where your vision blacks out. Well, because they pump the pressure up so high, it actually cut off the central retinal artery. But the answer is I don't, to my knowledge, no. So is this a glaucoma yes or glaucoma no?
Yeah, I was, the temporary, I had LASIK done, so the temporary amount that the pressure is up and then to come back down, I think to make that cut, I'm sure that there's compromise to the nerve fiber layer, but it's not staying up for days, hours, weeks. I don't know if back in the time when I was in a LASIK clinic, I don't know of any reported artery occlusions that ever occurred, vein occlusions that ever occurred. And then, yeah, that thin cornea, actually probably would overdiagnose because people would think that it would be easier to indent. So the thinner cornea does not increase risk is the other comment too, but I'll see if he made any comments. But I'm going to display this one, Joe. We're leaning there. We got 91, 89 saying yes, and 11 saying no.
And a great thing to look at, it is a glaucoma yes, because we look at the color. It's a nice tessellated fundus. You see how light it is here and how dark it is here. And the reason it's dark, because we don't really have much nerve fiber layer. And that looks to be right about where the rim tissue is. So this was a glaucoma yes. I see a lot more choroidal vasculature inferior than they do superiorly because of that pesky nerve fiber layer on top. We can't see it as well. Now this goes back to our very first question. Is this a glaucoma yes or a glaucoma no?
So Henry weighed in and said, I feel I've had some. I think it's the super high IOP during the procedure. So I would just say that maybe, but maybe it wouldn't be progressive, right? So maybe you had infarctions, maybe you had something, but the definition of glaucoma, that would be that it's progressive. So you're going to take away that high pressure. So maybe there's damage that you're picking up on in your patient population. But again, would it be progressive because that pressure is not high all the time? And it says, is the color of the prior nerve a concern? So I'm not sure. David, was that polling question 3? We can go back, but let me go open up this for number 4. So let me close, and open up 4. Okay, 4 is open. And then I'll keep an eye on, is the pallor a concern? I think if I go here, I can still see it. So yes, in number 3, Joe, if you want to toggle back, look at 3, then come back to 4, is that pallor?
No pallor, because this is all scleral tissue that we're looking at here. But the rim that remains is actually good. But what about this one? Is this a glaucoma yes or glaucoma no?
So that polling question is open. So the pallor that Joe is talking about is, if you look at this nerve here, Joe, if you kind of start superior and go nasally, look how well that nerve is pink. Go that way. There you go. That's in neuro disease. If that goes pale, that is the concern. Now, what happens in glaucoma when that neuroretinal rim atrophies away, you're able to see the scleral canal. So the nerve looks pallor. That's what happened in that number 3. Inferior, yes, it looked pale, but the neuroretinal rim is absent. It's dead. It's gone. Able to see it. The tissue that was still down below that was still perfused. So there was really no pallor in that 3 that would happen in neuro disease. So we got, Joe, I'll display it. We have 29% saying yes, and we got 71 saying no.
And this was a glaucoma no, but this was a great example of what somebody asked the very first question. What about temporal rim? And it looks like there is no temporal rim here. But if you look at the nerve fiber layer following the major arcades, it is very, very profuse. It's very, very healthy. I cut the bottom and cut in half. Bottom looks like the top. This is just an obliquely inserted nerve, congenital anomaly. We have to be a little concerned when we try to assess. The rules often don't apply when we have anomalous nerves. Now, let's put in some information. We've been just looking at objectively. We're good glaucoma practitioners. We're diagnosing based upon the nerve. Now let's screw everything up and give information. Which one? I'm going to show you 3 patients with some information. Which do you most suspect has glaucoma? Hint, one does have glaucoma. It's not a trick question. One patient does have. All right, let's take a look. Patient number 1, 28-year-old female. Pressure is 11. Central corneal thickness is 610. Let me digest it a little bit. Patient number 2, 56-year-old male. Peak IOP 22, central corneal thickness 598. And of course, use all the rules that we've talked about. We look at parapapillary atrophy, nerve fiber layer defects, neuroretinal rim defects, disc hemorrhages, any of those things, no pallor. So remember, do our disc analysis. That's patient number 2. All right, patient number 3, 64-year-old female, pressure is 31. Central corneal thickness is 490. So I'll let you digest that optic nerve. So we've looked at optic nerves. Now I gave you some information. Let's really screw things up. So polling question number 5, which patient has glaucoma? Is it number 1, number 2, or number 3? Bachelor optic nerve number 1, bachelor optic number 2, or bachelor optic nerve number 3. The dating game. We've been doing great objectively. Now I'm going to screw everything up and give you information.
Joe, maybe click through real quick one more time so they can see 1, 2, and 3.
No, that's not the rules here, Greg. Can't do it.
Okay. All right. How, when do you suspect a tilted nerve of glaucoma in a high myope? How and when do you suspect a tilted nerve of glaucoma in high myopia?
The answer is it's hard to tell. Some people say high myopia is a strong risk factor for glaucoma. Now we're talking about an anomalous nerve, and tilted optic nerves and even high myopia can have nerve fiber layer and field defects. That's when we start earning the high salaries that we get paid when we have to make those decisions. I think I might have an example of that coming up if we get that far. So, Greg, what does the audience say?
Okay, you're gonna like this. 1 is 9%. And then patient 3 goes up to 76%. And then patient 2 is 15%.
All right, so let's take a look at it. So which patient has glaucoma? Number 1, number 2, number 3? It is number 2, bachelor optic nerve bachelor number 2. If we take a look, we see that we cut it in half. There looks to be a little bit of thinning right there. And we have a corresponding nerve fiber layer defect. But the trick here, so to speak, number 1 and number 3 are the same optic nerve. So you correctly identify that this is probably not glaucoma because I biased you. I gave you a young age, a low pressure, and a thick cornea. Now, if I change it to an older age, a higher pressure and thin cornea, now it becomes glaucoma, but it's still the same optic nerve. So the important thing is, when diagnosing glaucoma, take pressure out of the equation. All right, if you say this doesn't have glaucoma, we have to say this doesn't have glaucoma. I led you down that primrose path of misdiagnosis intentionally, but they're the same nerve. But when I give you that information, you get a little bit biased. So we should take IOP out of the equation when we're trying to diagnose glaucoma. But when we manage glaucoma, we have to put pressure back into the equation. But that's an entirely different lecture. We'll cover in another webinar. All right, let me ask you, glaucoma yes or glaucoma no? 34-year-old female who comes in has a quote-unquote highly suspicious nerve. IOP is statistically normal at 13. She has an average corneal thickness and has been previously treated for normal tension glaucoma. There are the optic nerves. You can actually see large nerves, somewhat thin rims, and there's her field. So let you go back and take a look at the optic nerves, the way that we assess them. We give you the fields. Pressure's 13, has been treated for normal tension glaucoma, and there are the fields. Is this glaucoma yes or glaucoma no?
Caught up on the questions. And we got a good response to this one already.
You got
it. And we're going 55% no, 56% no, and 44 saying yes.
All right, so let's go back. I'm going to share a clinical pearl. Now, these are very large nerves. This would be a megalopapillae. Now, we can look and say, yeah, the superior rim is thin. My clinical experience, Greg, has been in megalopapillae, large optic nerves. I think we look at the vessel size, we can tell that these are large nerves. I typically see a thinner rim superiorly, and it's not pathological. So what we do is we repeat the field, and this is what shows up. And her field's unreliable. She was glaucomatous here. She's no longer glaucomatous here. She's not a great test taker. My advice to patients, if you insist on having a suspicious optic nerve, you better be a good field taker. Otherwise, don't complain if somebody treats you for a disease you don't really have. Now let's talk a little bit about the OCT and the ganglion cell complex or ganglion cell analysis. I think that's actually a fairly good term. And I know we talk a lot and we use another branded device, the OptiView, a lot of our examples. So I'm going to give a little bit of love to this device, the Zeiss, which I have used previously. And we can certainly see that we have these defects in the nerve fiber layer, and they are contiguous with what we see in the macular region. And when we put it all together, we can see that this is the same damage, the same defect. And the term I like to use is nautilus shell. It doesn't show up as well on some of the other devices, but on the Zeiss, it shows up very nice when you have a cut at the horizontal raphe and it looks like the nautilus shell. And Greg, I think that I may have been the first person that actually used that term because that's what it looks like to me. Other people have used the term squeegee, but I like nautilus shell. So we take a look at this patient, and we can certainly see here what appears to be a focal defect. It shows up here on the deviation map, but it falls within the normative data range. Now, when we take a look at the ganglion cell complex, and this is the same one we just saw right here broken up, there's that nautilus shell with a cut at the horizontal raphe. It falls outside the normal data range, and we have a false negative on this. Now, interestingly, some papers came out a few years ago that actually looked at the specifically the Zeiss OCT. Not just the Zeiss, and they looked at the parameters. They tried to look at the clock hours, the quadrants, the deviation map, the thickness map, and they compared it to what they said was the gold standard red-free photography. And what they found, they weren't doing ganglion cell at that time. They didn't really have a ganglion cell part component to the device. What they found, the parameter that was most sensitive and compared best with nerve fiber layer analysis, with red-free photography, was this right here, the thickness map. It was better than the deviation map, better than the quadrants, better than the clock hours. It was this. It was the thickness map. It was like just looking at it, they saw more defects. Now, some people call this a squeegee effect. I call it the Nautilus shell.
Hey, Jen, let me throw out to the audience. It's not a polling question. You don't have to put anything in the chat box, but I just want to ask the audience, do you consider glaucoma a macular disease, a disease of the macula? So just ask yourself that, that thought, if I were in the live audience, how many say yes? How many say no? And I want you to kind of go forward, thinking that glaucoma is a macular disease. Look exactly where these ganglion cells are. Look where they're dropping out. Remember, this shot is about a 6 mm cut whenever they do that through the fovea to the perifoveal area. So I want you to think that glaucoma is a macular disease, and that's why you start seeing some of these 10-2s and some of these other tests that are functional tests like color vision diagnosing glaucoma pretty early. So remember, glaucoma is a macular disease.
And I think this goes back to some of our early discussions, Greg, in terms of the reliability of the ganglion cell analysis and versus this. We have a false negative, but this really does show up very well. And I think a lot of the issue that we have to consider is there's a lot of anatomic variability in the retinal nerve fiber layer, but there's less anatomic variability in the macula. So that's why it is a macular disease, and we can pick it up by looking at the macula. All right, what about this? Glaucoma yes or glaucoma no? 62-year-old female who is a glaucoma suspect, 20/20 each eye, central corneal thickness has not been done yet. Pressure 17 to 18 range on multiple occasions. Biomicroscopy normal, angles are normal. And here is the nerve fiber layer and ganglion cell analysis on this device. We've got the thickness map, we've got the deviation map, we got the quadrant and clock hours, and we have the ganglion cell analysis. All right, so we take a look at this. Everybody's interpreting. Here are the fields. One is outside normal limits. The other is within normal limits. So I'll go back and show this to you again. All right. Is this a glaucoma yes or a glaucoma no? So I'm going to show you again so you can see. There are the risk factors. There's the nerve fiber analysis. There's the ganglion cell analysis. And there are the fields. So is this a glaucoma yes or a glaucoma no? What do you think? And in fact, I'll go back and leave it here for you while you make your determinations.
And I see a comment in the chat box about some people were replying in yes, nerve fiber layers in the macula, the ganglion cells in the macula, people weighing in macula, and then one of our attendees mentioned not until end stage. I wouldn't go down that rabbit hole too far. I like to know on a visual field if the macula is involved. I'd like to look at the ganglion cell to see how much the macula is involved. And my clinical pearl would be if the macula or the fovea is involved. I get a little bit more aggressive in my treatment. Sometimes you get that out there in that kind of that 20-degree zone or that 15-degree zone or that 24-2. But if it's up around those few points in the macula, I get a little bit more aggressive. So that's just my little pearl.
So what is it? Is it glaucoma yes or glaucoma no?
Well, this one's a little tighter. We're going to go majority. I'll display it now. We've got 52 saying no, 48 saying yes.
Well, let's take a look and we'll go back and analyze it again. Well, here are the optic nerves, and maybe if I showed you this first, you would have a different approach. All right, this is a patient. I forget what year it was, but what do we see here? Going back to 2012, this is an old photograph that was in the patient's file. What do we see there? There is a inferior disc hemorrhage, and now when I see her several years later for the first time, she has another inferior disc hemorrhage, and now a broad nerve fiber layer defect. So let's go take this and go backwards a little bit and look at her stuff. Now, what do I see here? First off, everything falls within the normative database here. But if you look at what I think is the most sensitive thing, is I have a wedge defect, and it does match that very well. Now, interestingly, what don't you see here? You don't see a disc hemorrhage. That's why we have to look at the patients. And we have this little cut here on the horizontal raphe, a mild nautilus sign. So all this comes together, and this is a glaucomatous patient. So we had the hemorrhage years ago, about 5 years later or so. What do we see there? Nice wedge defect and a recurrent hemorrhage. And this is indeed a glaucoma yes. But let's look at a couple of things. So this is why we have to look at everything in its entirety and not rely on just one thing. Now, this patient underwent 2 different OCTs. Here I've got something very suspicious to me, yet the patient falls within the normative data range. But if you look at the inter-eye asymmetry, while everything falls within the normative data range, there is a bit of a difference here. Now we look at the same patient on another device. This is the spectralis. What do we see? Well, it dips down below the normal range based upon this machine's normative database, and we can certainly see there is a degree of asymmetry. Yet, based upon the patients in each device, one triggers as being abnormal and the other does not. So we have to be very cautious when we interpret these. I'm not expecting anybody to have multiple OCTs at their disposal, but we can see how we have somewhat different results based upon what device is being used. And I'm not saying one device is superior or one is inferior. A lot of it comes to the normative database. Again, asymmetry, but not enough that falls out of the green on this normative database, but this one does.
Joe, go back to that one.
Sure.
I just want to see I think it was the Zeiss image. Let's compare the inferior neuroretinal rim values, because I like to use when they start getting about 10 microns, definitely 15 microns. So we can go off of that inferior quadrant down there. If you look, it says 125, I believe, and the other one says 105. And they're both in green, as you said, but the symmetry in between the eyes, if you look at the superior, what is that? 120, it's really small. 121 and 121?
121 here.
Go
So which
to
one
the
are we looking?
go to the quadrants right above it.
Yeah. 121, 121.
Yeah, see the symmetry?
103.
Yeah.
Mm-hmm.
Yeah. So what I want to point out to the audience is that that's what we call green disease over there in that left eye. It's not bad enough in that to get down below and flag it as yellow or even red. but the asymmetry should scratch your head on that one.
Mm-hmm. Excellent. All right, well, let's think about this. Glaucoma yes or glaucoma no? He's been a long-term glaucoma suspect. He was in our university clinic, so let's take a look at his data. Pachymetry 540 and 532, pretty average to me. His peak pressure was 32 and 31. We can see that he has been in the mid to low 20s. Now we take a look at his cup to disc ratio. 0.45, 45, 45 gets better, then gets worse. And these are different clinicians judging this. Gonioscopically is open. So we can certainly see that the subjectivity of cup to disc ratio really is not our friend. So we see his pressures, pachymetry, gonioscopy. All right, here's the OCT. I'll let you take a look at that. We can see the neurofiber layer is fairly robust in each eye. We have some departure from the normative database. We have a very large departure from the normative database here. We can see that it does flag in the left eye. And the ganglion cell complex, ganglion cell analysis, however, does fall within the green. I don't really see anything that is specifically impressive to me. But I think our eye will be drawn to this area here, which really falls quite a bit outside the normative data range, 39 versus a 52. So there is quite a bit of an asymmetry there. So the question is, glaucoma yes, glaucoma no. I'm going to be a little more specific. Yes, both eyes. No, both eyes. Yes, right eye only. Or yes, left eye only. And I'm only giving you a certain amount of information here. And I'm making the presumption because we really can't make a diagnosis just based upon an image, but we take a look at this. I'm going to leave this with you, or leave it here, and answer the question. Is it both eyes glaucoma? No, both eyes glaucoma? Or right eye only or left eye only? This will be a little bit more challenging. Have any other questions come in, Greg?
Let me get there. A 10-2 would be helpful in this case. That was just a comment. Is blue-yellow defect more likely than red-green with glaucoma in an early sign?
I don't know that the blue-yellow is helping us. I'm not sure red-green is. I think if anything, there might be a red-green, but we've had the swap field short wavelength automated perimetry where they had a yellow bowl and a blue light trying to isolate the blue fibers. I don't think that ever really panned out. What are your thoughts, Greg, in terms of red, green, or blue, yellow?
Yeah, so I think there's two ways. He might think Matthew might be asking us two ways. I agree that when they came out with CETA, I'm going to answer your question and then go back, I think, and go down a different rabbit hole that Matthew's going down. Is that I agree when they came out with the CETA standards and then all the different thresholding, that's whenever the blue yellow visual field died away. Whenever it was the black yellow background, urine colored background, blue light, because there was less blue photoreceptor, so on and so forth. That all kind of fell out with white on white when they got the better with the better testing that's out there. So that's on visual field testing, white on white versus blue yellow. That's that answer. But is there, in the Rabin cone contrast, and you've seen that at our events, Joe, live events, and I have it in the practice. And so diabetes and macular degeneration and glaucoma kind of have specific patterns. but it's usually asymmetry. I'm going to go back while this is going on. There are now some signs where diabetes leans kind of towards the blue or to the red or to the green. That's starting to come out now with this testing being done more and more. Let me see if I can find that for you real quick, Matthew, in my notes. So that would be specific type, not your Ishihara test, though. This would be something that is like color vision on steroids.
So what is our answer here? Is it glaucoma yes or glaucoma no? What do we say?
We have a nice mix. We have A being 21%, B being 32, 11% for C, and we have 36. So if you're going to go with your winner, it's D, yes, left eye only, or
All
B,
right.
both eyes do not have it. So,
All right. Well, let's look a little further. So our eye is drawn to this area. So that's what I want to look at. I see a little bit, little paucity here. I don't see a frank nautilus shell. So let's take a look. And I look in this area. The nerve looks fine to me. I see no disc hemorrhages. I see no focal defects of the neuroretinal rim. I have say a little change right here, little defect, but it stops at that arterial. So that's a pseudo defect. But I want you to pay attention at this one right here. And what do we see there? We see a large wedge defect. So let's go back and take a look. It doesn't really fall, comes off maybe as borderline. Maybe a little bit of a potential defect there. That one looks kind of like a defect to me. So our attention was drawn, like the magician, I follow my hand here while I'm doing something with my other hand. That's kind of what's happening to us. So when we look at the patient, we look at the disc analysis, the nerve fiber layer analysis, we do see a large wedge defect. And now we look at his field. His left eye was clean, but he has had 1, 2, 3, 4 defects in the same general area that matches this. And was he really a glaucoma suspect? The answer is no, he actually had glaucoma. All right, 66-year-old female, 2020, angles open, thin-ish corneas, peak pressure, 18 and 16. Is this a glaucoma yes or a glaucoma no? So I'm going to let you take a look at this. Now there's the optic nerve. We have the nerve fiber layer, and got a nice red free. Now the important thing to do here is also look for symmetry, bottom and top. Look at our nerve fiber layer symmetry, bottom and top. Let's look at the other eye. We see the optic nerves, neuroretinal rim. Again, let's take a look. It does help us see the rim tissue in red free. Look at the nerve, bottom and top. Look at the retina nerve fiber layer, bottom and top. Is there good symmetry here? We'll take a look at this. Here's a nerve fiber layer on a Zeiss OCT. We can see the quadrants, the clock hours, and their statistical significance. We can look at the thickness map as well as the deviation map. We take a look at the ganglion cell analysis here. And you see the deviations. We also see the thickness map there. So is this a glaucoma yes or a glaucoma no? Let's go back and take a look. I'll give you all two again. Thin-ish corneas, peak pressure 18 and 16. We look at the optic nerve. We're going to cut the optic nerve in half, look at the bottom and the top. We're also going to cut the retina in half, look at the nerve fiber layer above and below in both the right eye and the left eye. We look at the nerve fiber analysis. We see the quadrants and the clock hours and their statistical significance. We can see the deviation and the thickness maps there. And I guess you do call it GCA, the ganglion cell analysis, the ganglion cell complex analysis. We see the thickness map and the deviation map. And I'm going to ask you now, based upon what we've been talking about tonight, do you call this a glaucoma yes or a glaucoma no? What do we see there, Greg?
We are having people rolling in saying it's starting to separate. I've been watching it. Let me give it a little bit more because a few people.
Okay.
There we go. It's starting to weigh in.
They're getting a little harder now.
I've been watching the numbers. We've been getting about close to 90 people weighing in, and now we're there now. Boy. Well, it just separated again. So we got 51% no, it just hit 50-50. So it's
So we'll stop it there then. All right. Well, we take a look in the final piece of the picture is the visual field, and we can see that there are inferior arcuate defects. So let's go back. And we can see the nerve fiber layer, the ganglion cell complex is unimpressive, but I do have some cuts at the horizontal raphe, which are very pertinent to me, Greg. And I take a look, and even though we fall within the normative data range for the most part, that there looks to me to be a nerve fiber layer defect. And we take a look, if we look at the bright nerve fiber layer here, I don't see it quite as good up here. And the same thing, I've got a little brightness down here, but it's a little darker up here, and maybe there's a hint of a nerve fiber layer defect. And we put it all together, and it does match what we see. So this would be a glaucoma yes. Not an easy one, not easy at all. And this is actually one of my more recent cases. I just saw him not all that long ago. Is this a glaucoma yes or a glaucoma no? He's a 56-year-old male, 20/20 in each eye, thin corneas, 473, 495. Gonioscopically, he's open, a ciliary body, both eyes, no abnormalities. His pressure has ranged from 19 to 26 in the right eye and 19 to 23 in the left eye. Diabetic, hypertensive, high cholesterol. He has a heart stent. He's on atorvastatin, losartan, carvedilol, and Ozempic. Now here is his OCT, and we got a good breadth of different devices in tonight's lecture. Now this, I think, in my opinion, looks artifactual to me. What is your thought there, Greg?
Oh yeah. Yeah, I agree. Let me
Yeah,
see we're looking at if you look at the B scan down there, Joe, you can see that it's grayed out there on the left if you point that out. Good, see right there. That's why.
Yep. So
if you look at the one down below, look at the one down below.
So this, while this is impressive, we can see that there's missing data. So this is artifactual. All right, so that's what we have here. We're good so far. Here's his field. And he's a young, good field taker. Looking pretty good. And here's his optic nerves. So I'm gonna let y'all digest that for a second, and based upon everything that we have looked at, I'm just gonna leave it. I'm just gonna leave it here for a few seconds. So let's go back and take another look. All right, so he's in his 50s, good acuity, thin corneas, gonioscopy normal. His pressure has been 19 to 26, 19 to 23 on different visits. I had only met him one time, so he had been seen in our practice previously. He has got a few issues health-wise, but nothing terrible. He was not a sickly sort of person. So we take a look in on the OptiView OCT, and we can see his nerve fiber layer. And it said, as Greg points out, we're missing data, so this is going to be artifactual. I'm going to help you out and tell you to ignore that. This, however, may be legitimate, so we have to consider that. We look at the inter-eye symmetry here. Here are his visual fields. And remember, we started to talk off by the importance of looking at the optic nerve and properly analyzing the optic nerve. So I'm going to leave you with the optic nerves right there and tell me what you think. Give you a chance to all look at that. If we have 90-some people weighing in, Greg, that's pretty good response for our audience.
Yeah, you don't have this polling question open yet, do you?
No,
I
not
don't.
yet.
Okay.
No, not yet. We're about to get there.
Okay.
So it comes down. Glaucoma, yes. Glaucoma, no. I'm gonna give you an escape route here. Glaucoma, I'm not sure. Or maybe I should say glaucoma, maybe.
So I found my notes with regarding the kind of the Ray-Ban cone contrast, which I love doing. I'm starting to get some progression in the practice, and AMD in glaucoma often begins with red and or green damage. I dropped the slide in at the very end, Joe, when you're done. Before I do housekeeping, I'll show. Diabetes is definitely blue. Neurological, all three cone types. And then cataract will affect the blue before the red-green. So it's been really cool catching it. I love using it for progression is where I've been able to use it. So it goes back to that old function, structure versus function or structure. Depends on what function or structure. If you're talking visual fields versus OCT, I'm going to lean towards OCT. These other tests that are out there, like dark adaptation, that was a function test. We just didn't know really what to do with it, how to treat it. But that's to pick up macular degeneration early. Color vision can pick up these things early. VEP, ERG testing can pick it up early. So we got to be careful. Most of us just have visual fields and OCTs in our office. So we like to say structure, but if you had a lot of devices, you might lean and say function will pick things up early. So, all right. You ready for your results?
Yep.
All right. A, 16%. No, 56 is your winner. And 28 is I am not sure.
Right. Well, I left this up here for a reason because I think the most important thing is right here. Let's go back and analyze. Yeah, everything is pretty robust here, but we do have a little bit of an abnormality, which may or may not be real. So I will acknowledge you on that one. But we have pressures is going about as high as 26 and 23 with a thinnish cornea. But I told you the most important thing to do is look at the optic nerve. And what do we see here? I've got good nerve fiber layer here and here. It's pretty symmetrical to me. But I take a look, and what do we have here? This is actually a fairly significant wedge defect. And we don't see quite the same thing down here. The nerve itself is still good, but the parapapillary retina is not good. We can see that delineation between good and not so good tissue. So this to me, despite the fact that he has good fields, would be a glaucoma yes. And that brings me to another polling question. I'm a little over ambitious tonight, Greg. We're not going to finish the entire lecture, but I'm having a heck of a good time. Hope you are. Hope everybody else is. If this is a glaucoma yes, what are we going to do? Are we going to treat him with meds? Treat him with SLT? Observe him? Or something else? And if you want to do medical treatment, what medicine would you use? That should be just something else. Forget the rest of it. So do you want to treat this guy with meds, treat him with SLT, or just observe him?
Okay, that polling question, they're rolling in. And we go to the chat. So everyone, thanks for making this synchronous tonight. Lots of activity, lots of polling questions, lots of happening in the chat box. So, all right. Thank you for looking into that. I got them all for you, Matthew. I'll put it right at the end when I switch over to the housekeeping. My pleasure. That's why we're here to learn. And I keep all my lectures in the cloud so I can always reference them. So I know it's where I did it. So can't keep it all memorized. Is there ever a time when you might check contrast sensitivity?
I myself do not. I find that more pertinent with some other neuropathies, but not so much glaucoma. I'm not saying it's wrong. It's just nothing that is in my practice.
And then back to one of your scans, would the vitreomacular adhesion, VMA, especially right eye on the GCC, influence the readings?
Clearly,
So,
yes.
yeah. And then more importantly, when it releases, if it releases, you can get a few micron shift.
But it's important to look at everything on the printouts and acknowledge when that happens. Sometimes when a change occurs, we have to say, is this a pathological change or is this some sort of anatomical change? That is not true disease. So what does our audience want to do with our fellow? Treat them,
Let me
SLT, meds, or observe?
okay, let them keep weighing in. How do you weigh in normal tension glaucoma risk factors like uncontrolled OSA, etc., on glaucoma risk, or is that just a concern mainly for current glaucoma patient?
Uh, Hit me with the question again, Greg. I'm not sure
How
I
do
get.
you weigh how do you weigh in normal tension glaucoma risk factors like some uncontrolled OSA, comma, etc., on glaucoma
that
risk,
that that
or
that.
okay, or is it just a
But
concern mainly with the current glaucoma patient?
I don't think OSA is going to be. I would think about it in the terms of a glaucoma patient, not just OSA itself. It doesn't mean that they will go on to develop an ischemic neuropathy or they'll develop normal tension glaucoma. But interesting, Greg, I had a patient today who came back for some repeat testing, and his pressure has been down in the 15 to 16 range. I think he began in the low to mid, about the mid 20s, and he has gotten worse in his left eye. I've demonstrated over three that his OCT in one eye got worse, and his visual field got worse, but his pressure was 13 in that eye. So that's why we follow them. I'm not really sure what is there something else that is contributing to that progression? The answer is possibly, probably, but he's going to be off for cataract surgery and stent implantation, and maybe that there's a better diurnal control on him. So that is a person that may have other risk factors that have not been identified, and why he's getting worse in one eye at what should be a reasonably good pressure.
So
So
that we
let's wrap.
don't get the comments of throwing out acronyms, because Joe and I do read the comments and try to make these as best learning experience. OSA, obstructive sleep apnea, for those out there as we toss it around, obstructive sleep apnea, OSA.
Mhm.
Joe,
So what do we?
the display to I've been displaying it for the audience. 42% want to treat with meds. 37 will go with an SLT. 20 are going to observe, and one put something else if medical treatment. What medication? And I'll check the chat box. So 37%. Oh no, sorry. Treat with meds was 42% as the winner. Close runner up, 37% SLT.
I think meds or SLT is very good. If you're going to follow a patient like this, you follow them very carefully. But thin corneas, elevated pressure, and neurofibrillar defect get good field. Young age, I would probably lean toward treating, but meds or SLT would be very reasonable. We did treat him with meds. So I'm going to wrap up. We have oh geez, how much more I had to get through? Just too much.
Looks like we
Got a
need a
little
part two.
ambitious. Yeah. Well, hopefully everybody enjoyed. I had a very good time, and hopefully it was great. So with that, I'm going to stop sharing.
So there was a comment that
And
came up. It says, in our group practice, OD or MDOD, I always push for the SLT first line. So yeah, I think that that is leaning that way with a lot of what's coming out, these low lasers, low level, 360 degrees, very low level SLT, all kinds of cool things coming out. I think we'll probably be leaning more towards SLT in the future. So, so you just got a comment, Joe. Let's do a part 2 soon.
All right.
All right. So let me jump in and share my slides here. And it's this one here, I believe. Is what I want to share. Okay, so right now, if you look at your screen, you'll see right here, there's a little red circle. You can start that survey if you'd like, and you don't have to wait 7 minutes for the post-event survey. If you want to wait the 7 minutes and do it later sometime, that's fine. This goes to Matthew and interpreting like a Raven cone colored test. Macular degeneration glaucoma often will be red or green. Here is diabetes being blue. Neurological is all three. Then you got to be careful with that yellow cataract. And this is what it looks like. I have it in the practice. Here's the test. You do it in the dark. He's wearing his bifocals. You have to patch an eye, and what we talk about leaning, this is what we call leaning. As you can see, his glaucoma is worse. He has glaucoma in his right eye, no glaucoma in his left eye, or minimal glaucoma, but you can see how it's kind of leaning towards the green. He does have a cataract in here. I think this is some cataract, but you can see how the green is affected. So that's what we talk about whenever we do this test right here. So that's a little 2 cents. So, Joe, I can't really see the questions anymore, but I can go back and take a quick look. Maybe you could see them. I just want to make sure there's nothing else in there. Let's see. I can get there. You're getting your kudos. Part 2 soon, and great presentation as always. I enjoy this talk, or you pulled it all together. I've seen it in maybe bits and pieces, but what a great talk, Joe. You could see that you definitely have a good grasp. You do this in the office. You're speaking from clinical experience. I want to thank you for doing glaucoma, yes or no. I think anyone out there treating or trying to diagnose and make a referral definitely got a benefit from this optic nerve assessment, then folding in the OCTs and the other testing.
Well, thanks, Greg, and thanks for helping out. You had the yeoman's work. You had all those polling questions. I still need to get out to all the presentation, but you did a great moderating and helping me out because I can't see any of that. But Greg, I've done so much glaucoma education over my career that I've kind of drifted away from it. My interest in, as you've seen, has been between the neuro-ophthalmic disease. I really like doing that. But it was good. I enjoyed this. I had a great time, and I hope everybody enjoyed because I'm glad we dusted this one off and brought it back into the lineup. So I had a very good time, and I enjoyed working with you, Greg, and thank you for helping out so much.
My pleasure.